Hello and welcome everybody. I'm Subhash Chandra and welcome to our American Foregut Society's monthly webinar. Today we'll be talking about Barrett's esophagus, kind of diagnostic aspect and surveillance options. Our first speaker is Dr. Prakash Gata. Dr. Gata has done medical school from Mumbai and his surgical residency from University of Illinois. After that, he has done minimal invasive foregut surgery fellowship at Houghton, Oregon, and now works in Tacoma, Washington at Multicare Medical Associates. And he is the foregut guy in Puget Sound. He does links and tip surgeries for refractory GERDs and have been selected as America's top surgeons by Consumers Research Council of America. He'll be talking today about biopsy protocol and use of WATS in evaluating Barrett's for dysplasia. Dr. Gata.
All right, thank you, Dr. Chandra, for the introduction that I don't deserve. I appreciate the opportunity to speak here. I think for me, looking at Barrett's disease, esophageal cancer, and reflux as a continuum or a spectrum, and looking at it or researching from a diagnostic side, I've learned, I feel a lot, some of the things that we don't always see as surgeons. So one of the things that I wanted to set as expectations is if you're a foregut surgeon or that's kind of your clinical interest, I would look at esophageal disease as a pyramid. So the very tippy top of the pyramid is what we want to prevent, which is esophageal adenocarcinoma. And one of the things that over the last few years has been quite clear is that we have failed in finding a way to reduce the incidence of this particular cancer with almost an 800% increase over the last 30 years. And this is multifactorial, but I believe part of the failure is our inability to come up with standard screening or diagnostic tools. Clearly that there is some correlation between the payer side as well as the ability to understand the disease as a whole. So it's one of the fastest growing cancers, certainly one of the fastest growing GI malignancies, and it's one of those potentially preventable cancers that we, as opposed to cervical and colon cancer, which the incidence has stayed flat. Esophageal cancer, not so much of the case. In terms of treatment as well, it's a difficult cancer to treat, even if you were to diagnose it early. And as you can see, the 5-year survival rate has not been a significant increase over the last 20 or 30 years. So a big issue is what we're trying to do is find better mechanisms, essentially fix the problem that we believe is a problem, part of which is diagnosis. So in terms of if you're a diagnostician, if you do a lot of upper GI work and you're a gastroenterologist, the average gastroenterologist sees 20% of who they see are reflux patients on a daily basis. And as we all would know, there's a lot of specialists who also treat this disease, ENT, dentists, gastroenterologists, and pulmonologists. And along that care continuum, that spectrum, is a change in the mucosal pattern of the lower esophagus, essentially something that arises after years and years of damage from this acid and non-acid reflux, an irreversible change. We know, and that we call this Barrett's disease, Barrett's metaplasia, as well as dysplasia. And we also know there's a higher correlation or incidence of esophageal cancer with patients with this. Barrett's, the presence of Barrett's, the current way to diagnose it, at least endoscopically, is using NBI light as well as experienced gastroenterologists, the protocol to be able to find and create a biopsy-proven area of dysplasia, which has a far higher correlation with esophageal cancer, is essentially our challenge. So this is what Barrett's disease would look like. So in terms of progression of the disease process, the change is essentially a change from squamous epithelium, which is then suffered by GERD and affected by GERD, a transition to Barrett's esophagus. And within the Barrett's metaplasia, the crypts that are formed, because now these are columnar cells, the crypts that are formed are usually likely the location for the dysplasia. And then there's 2 grades of dysplasia. low grade and high grade. High grade dysplasia currently can be treated as esophageal cancer. Between 4 to 18% of patients will actually have occult adenocarcinoma at the end of the esophageal resection. And part of the diagnosis is to do an endoscopic ultrasound on patients that have higher suspicion for this disease process. So 20% of the US population will develop GERD. 8% of that 20% will develop Barrett's esophagitis. And the pathway of progression of that cancer will continue. Patients with Barrett's esophagitis have a 50 times more incidence of esophageal adenocarcinoma. And this is why surveillance and screening of Barrett's esophagitis is essential. This is one of the reasons we believe is the better screening is a better, more effective way of controlling this. So of the US population of 330 million, 66 million will develop GERD. So a huge denominator in the disease set that's out there. This is a busy slide, but I don't know if you can actually see the current surveillance, the current acceptable or accepted surveillance mechanism is essentially to follow the Seattle protocol. So you have to obtain tissue to diagnose the lower esophagus and to establish the diagnosis of Barrett's esophagitis. And once those histological findings are found, presence of Barrett's metaplasia, whether the biopsies are indefinite for dysplasia, typically what we do is recommend a rebiopsy at 3 to 6 months after initial treatment. But if there is an established diagnosis of Barrett's metaplasia and there's no evidence of dysplasia, typically we would survey these patients. Patients that are indefinite for dysplasia, sort of in between dysplasia and metaplasia, we would confirm the findings with a second pathologist, someone that would be considered an expert pathologist for esophageal disease, as well as follow-up endoscopy down the road. And if there is evidence of high-grade dysplasia or esophageal adenocarcinoma, of course, the patient will follow the pathway of the local sort of the cancer protocol where you have an esophageal surgeon see said patient. So what is the Seattle protocol? The Seattle protocol basically is the mechanism to obtain tissue biopsies using random 4-quadrant biopsies separated by 2 centimeters in the distal esophagus. And in patients with an established diagnosis of patients with suspected dysplasia or an established diagnosis of prior Barrett's metaplasia, it is recommended that there's a biopsy be performed every 1 centimeter. Now, what are some of the flaws of the Seattle protocol is that in terms of the amount of tissue sampling that is obtained, there's a huge resource. This is a resource-intensive mechanism where it's tissue-consuming, it's time-consuming to obtain those samples, have every of those samples, evaluate pathology. Most importantly, are you getting enough tissue, especially in the area where dysplasia may start, essentially deep down in the crypts. And if you look at the sort of biopsies that you obtain, there are still areas that are deeper from the superficial zone where tissue is not obtained. And more importantly, there's a lot of sort of user variance in terms of what Seattle protocol actually is, depending on training, local cultural practices, as well as the differentiation between pathologists who typically will review a higher volume of lower esophageal biopsies. So there's a lot of variation from the perspective of screening. And the goal essentially is to prevent or early diagnosis of esophageal cancer. There's been data that shows that the Seattle protocol does not necessarily equate to a higher 5-year survival rate. So this is essentially the goal of that diagnostic process. So to summarize, the sampling error is associated with a higher rate of sampling error in terms of intestinal metaplasia and dysplasia. Secondly, significant amount, this has been studied, a significant amount of inter-observer variability in terms of what the slides are actually representing. So 33% of esophageal, in this particular study, 33% of esophageal adenocarcinomas were diagnosed in this subset, in this particular study, on a patient that had a negative Seattle protocol index biopsy a year prior to the procedure. There was no significant mortality reduction at 5 years in patients where Seattle protocol was borrowed. So enter the WATS instrumentation. I present this as a way to essentially differentiate between the typical superficial biopsies as well as what a WATS instrument biopsy would look like. In terms of where the dysplasia is, these are the red cells that are deeper down in the crypts, the tissue diagnosis that we actually want. So those crypts are much better accessed using the WATS instrument. The area of tissue sampling is larger, and how WATS is different is the tissue obtained is run through a vision platform using artificial machine learning intelligence software that would allow for every biopsy is still reviewed by a pathologist, and I had a chance to connect with a company to figure out how a pathologist can obtain a specimen from a patient in Washington State where I'm at. How the pathologists work with this particular company is once the biopsies are obtained and these biopsies are run through their machine learning algorithm, what would happen subsequent to that is the biopsies that are concerning are red flagged to an expert panel of esophageal pathologists. And these pathologists have national licenses in all states, or how, as is governed currently, where the specimen is going, which is typically New York State, the pathologist has licensure in that particular state, so it's usually covered. But for pathologists, not something I've had to think about before. If you send it out to another state, typically where the specimen is received in that particular state, the pathologist on that state can see that. But they have an expert panel who review every slide. And the difference between the technology is significant because a combination of the Seattle protocol with the WATS biopsies appears to correlate to a much higher rate of diagnosis of Barrett's esophagitis. Again, this is a good way to sort of summarize what happens. It's an interesting combination of an endoscopist performing the biopsy with this instrumentation, a machine learning algorithm that actually sorts through the histologic slides to look at which of these specimens actually are of concern, and then another one with a human being trained and specializing in this particular disease set that can review these particular slides. So this is a 3D rendering of what the specimens would look like using this particular instrumentation. Let me see if I can get this to play.
During an upper endoscopy, highly focal dysplastic cells are often hidden among mucosal areas of the esophagus, usually without any visible clues to show the clinician where they may be located. WATS 3D uses a specially designed biopsy instrument that covers a greater circumferential area of the esophagus, providing a wide area, full-thickness mucosal tissue sample down to the muscularis mucosa, gathering cells, cell clusters, and intact tissue fragments in a unique disaggregated specimen that is up to 150 microns thick. To overcome the challenges of a tissue sample that's 50 times thicker than a traditional histology specimen, WATS 3D uses a proprietary 3D imaging system with extended depth of field to capture all the layers of a thick smear into 20 to 40 independent sections, all in precise focus. CDX's patented technology merges the digitized slides into a single synthesized 3D image. This unique dimensional view of the specimen presents a much clearer image of cell nuclei and mucosal crypt structure, enhancing the pathologist's ability to examine cells in relationship to each other, ultimately leading to a more accurate diagnosis of Barrett's esophagus and dysplasia. Once the whole slide is scanned, artificial intelligence is employed to reliably identify dysplastic aggregates hidden among normal esophageal tissue. A neural network trained by expert pathologists uses an advanced algorithm to consistently analyze every pixel of the digitized specimen. First, the algorithm looks at a variety of lower-level features such as texture, color, shape, nuclear size, and nuclear cytoplasmic ratio. Then, it evaluates a combination of individual lower-level features, groups, and clusters, and compares these findings to a previously learned training data set. Finally, the computerized cell images are highlighted and ranked according to their degree of atypia. Areas identified by the AI system with the highest probability to be precancerous are then displayed via computer monitor to the pathologist, allowing them to quickly and accurately identify dysplastic cells that may otherwise have been hard to distinguish or even missed completely.
Essentially, it's very interesting software and sort of employment of latest technology along with human knowledge. And the result appears to be that, number one, there appears to be a lot more inter-observer agreement amongst pathologists with the newer mechanism of tissue sampling. And it also appears to translate into a much higher detection of the disease set that we're trying to not miss. So, and up to 167% increase. The yield is higher. There's a lot less disagreement among pathologists about the diagnosis, and hopefully this would translate into a lower rate of these cancers, 33% as we saw on that particular slide, a lower rate of missing these and earlier detection of the disease. So I appreciate the ability to present this very interesting subject for our webinar.
Thank you, Dr. Gata. We'll come to the questions at the end. Our next speaker is Dr. Houghton. Dr. Houghton is from Los Angeles, California. She finished her medical school at Wayne State, followed by residency at University of California, Irvine. She completed her minimal invasive surgery and advanced endoscopy fellowship at University of California, San Diego. Currently, she practices under Keck Medicine at USC. And she is well known for her expertise in robotic foregut surgery and pioneered their POEM program. She'll be discussing about Cytosponge, biomarkers, and optical imaging in Barrett's surveillance.
Hi, how are you guys? Thanks for having me. And you know, Prakash's portion of the talk really sets us up for then what else can we do? And as we know, from what he said, Barrett's diagnosis is in diagnostics traditionally has been the use of endoscopy with the combination of pathology. So you want to see the salmon colored tongues and mucosa endoscopically, and then have that pathology confirmed with the goblet cells in the esophagus. And as we communicate this with each other, and as we're diagnosing patients with Barrett's, we tend to use the PROG classification to document the circumferential margin and then the maximal extent. So as far as standardization of Barrett's, we'll often see that, you know, we can gauge from endoscopy to endoscopy whether this is progressing, regressing. And I think it's important for all of us to know kind of the standardization of how to report it on endoscopy. We'll see the circumferential margin maybe 6 centimeters from the G junction, like in this diagram. And then the maximal extent, there may be one little tongue that comes up a couple centimeters more. So he'll report the C as the circumferential and then the maximum. This will help with just how we go about communicating to each other between GIs and surgeons about Barrett's disease. But as we know, and what has been highlighted already, is that there's limitations for not only once we see Barrett's, okay, yeah, you saw it, you wrote it, you wrote down how extensive it is. But then what do we do from there? What do we do with those patients? How are we going to screen them? We know that the incidence of esophageal cancer is increasing, and Barrett's is the precursor, and yet we don't have protocols for the population-based recommendations for screening patients. And EGD is expensive, so that tends to lead questions of who to screen and when to screen. So there's a lot of companies out that are coming up with new ways or better ways to help screen the population at baseline. How do we do that if patients can't get an endoscopy because that's too expensive to screen the entire population? And then with the patients with Barrett's, how do we predict who's going to go on to get esophageal cancer. How are we going to better diagnose dysplasia and metaplasia and kind of classify them with their Barrett's to know their true risk? WATS is a great adjunct to the Seattle protocol, but what else can we do? Well, the Cytosponge is a very interesting idea, and it's actually, one of those, it's a population-based screening tool without endoscopy. The Cytosponge is a small little capsule that can be swallowed by the patient, either usually in a clinical setting. It expands like a grow a sponge, like when you were little and you put the sponge in water, and it grows inside the stomach. And then it's connected to a little string that you can pull out, and it scrapes the inside of the esophagus to give cells for pathology. It's easy, it's non-invasive, it's affordable screening test. Basically, how they then analyze the cells for this trefoil factor 3, which is one of those factors that's seen in Barrett's. The sensitivity and specificity for this is good. So this is a video of how this Cytosponge works, and hopefully it will play. There we go.
The Cytosponge test is a simple solution for collecting cells from your esophagus, food pipe.
Enjoy the British accent.
This innovative solution uses a small capsule-shaped device the size of a multivitamin pill. A thin string is connected to a sponge inside the capsule. When you swallow it with water, the capsule dissolves and the sponge expands in your stomach. The string is then gently pulled to retract the sponge. As it's retracted, the sponge collects cells from the entire length of your esophagus. Cytosponge, a simple solution for collecting esophageal cells.
So that's the overview. I think this would be great because most of the patients that we're screening or that we're seeing in endoscopy are the patients that have a GI doctor that complain to their PCP. And I think a lot of the population is missed because acid reflux is such a common problem, and there's so much ability to self-medicate that patients may have chronic acid reflux and don't even think that it's a disease that needs a clinician's help to treat. They'll self-treat. So this would be something that could be done in a PCP's office. I think it's an exciting innovation. I don't know how it feels necessarily. I haven't done it myself, but I think that would be a limiting factor, is how uncomfortable it could or may not be. This is not commercially available in the United States yet, though. They've done testing in the UK, but it's not commercially available in the US. But this is one of those things that if we could get to the population may help with screening. So other imaging modalities, now we're going to switch gears a little bit to the patients that we know have Barrett's, and yet we're missing the patients that are going on to get esophageal cancer. So what do we have in our toolbox to help us kind of treat the patients that we know already have Barrett's, besides the Seattle protocol, besides just biopsies? The one thing that Prakash mentioned already was NBI. This is kind of part of your standard endoscopy and screening for Barrett's. It's done during an endoscopy. Most endoscopes have NBI available by the click of a button. So this really should be part of the standard protocol. Basically, it filters within the endoscope to emit a certain wavelength of light to visualize the mucosal patterns and highlight the mucosal patterns a little bit better, so that we can look for areas of metaplasia or evidence of dysplasia and help guide our biopsies a little bit to the high yield areas. It's about 90% sensitive and specific. It's easy, it's click of the button. I think most endoscopists are very comfortable with narrowband imaging, and this is, I think, used routinely. It can help pick up metaplasia versus high-grade dysplasia. Intestinal metaplasia will look like fine capillary patterns with this ridged or villous pattern. And high-grade dysplasia and even intestinal neoplasms have increased capillaries with tortuosity and a dilated or corkscrew pattern. So these are just some examples of how you can use MBI to pick up areas that are high risk. There's other imaging modalities out there, so the next one I'm going to talk about is cell visio. So cell visio is kind of like a probe. It goes through the scope. It's a through the scope probe that can visualize the mucosal areas up to 150 microns deep, which is the area where you'd find Barrett's. And like Prakash said, that's where those crypts are, and that's where we can really see dysplasia. So it can visualize those areas and give us a better, it almost gives us a histologic image without sending tissue to pathology. So we can see that endoscopically, that histologic pattern endoscopically. You do have to give IV fluorescein or some kind of dye in order for this to work. And it's highly sensitive and specific. Here's some pictures of kind of how that works. It's a through scope probe. And then on the endoscopic image, you focus the probe on the areas of the Barrett's where you want to look. And in the bottom picture, you see that histologic pattern. You can see it enhances, allows us to almost be a pathologist during the endoscopy. Here's some examples of the images you could see and kind of the patterns that would alert you to pick up metaplasia or high-grade dysplasia. The normal, A is normal. B, in that picture, we see some intestinal metaplasia, enhanced nuclei, and some of that enhanced pattern of metaplasia. And then Barrett's esophagus on the far, the right side of the screen. The other thing that's nice about this technology is that it can be used in the esophagus, it could be used in the stomach, and it's even been used in the bile ducts like ERCP. So it's very versatile at looking at this histologic picture, and it can even pick up H. pylori, for example, in the stomach. You can see in these pictures, they're saying these little white bright dots is H. pylori, and it correlates to the pathologic staining at the top. You can pick up not only that they're present, but then also how much of it is present in the load of H. pylori. This is a very interesting imaging modality, and it does help us see that histologic pattern, but you have to know what you're looking at. And I think that's been kind of the limitation to this modality, is that you have to have training. You need intense training to know. You can see those pictures and see the histology, but you almost have to understand, like a pathologist, what you're looking at. It does survey high risk patients. So where I think this could be useful is in clinicians that are specializing in Barrett's and treating those patients. And we need screening to see if there's some high grade dysplasia or concerning areas. I think this could help. It can guide biopsies to more suspicious areas. So if we learn those histologic patterns, it helps target very high risk patterns, and it can also help guide EMR. So if you find an area of high grade dysplasia that may be indicate you could do EMR for, this can actually help not only find the margins of where you need to resect, but also determine the feasibility of EMR. I said at the beginning, it was only 150 microns. So if you see that the distortion going deeper than that area, then maybe this patient is not an EMR candidate at all, and would have to go to a surgical intervention or have some other modality. So I think there's limitations, but I also think that this could be very helpful in the right hands. It takes some time and training, but I think when used right, this could definitely be a benefit. 9-point is another one of these types of modalities that can help endoscopically visualize tissue. This is more like endoscopic ultrasound. It quickly obtains cross-sectional area and longitudinal images and shows irregularities within the mucosa. It has a very interactive user face, so you can kind of scroll up and down on the screen. It's a touch screen. And it can also mark targeted areas. And I have a video that shows what this looks like. This doesn't have video, so or sound, so I'll kind of talk over it. But you have this joystick. This is your navigational pad, as it says. And then a laser trigger, and that's used to burn or mark areas that look concerning. So you have some kind of indication on the mucosa of where that area is. Through the scope, you place this balloon that you then inflate in the esophagus. And then you have this imaging probe. You can see in the video, it's spinning and it's traveling up the esophagus and taking these cross-sectional images of the esophagus. And this is what it kind of plays out to. So now we see the cross-sectional images as we go along, spanning the whole area of Barrett's, and then there's an irregularity there in the mucosa that we can target, and you can press the button to make these little burn marks, and that can show you the border of where that irregularity is. I feel like this, it's so this modality in the studies that I looked at had some inter-observer variability is high as far as what you're looking at and deciding what is irregular and what's not. There is, again, training and skills required in interpretation. It's similar to EUS. So you have to have that skill in interpreting what you're seeing, similar to that of ultrasound. It is expensive, and the other drawback is it's not very versatile. So Cellvizio you could use in the esophagus, you could use in the stomach, bile ducts. This is a balloon. It's really tailored to the esophagus. And so that's been one of the criticisms of this imaging modality, is that it's almost too niche. But for Barrett's, if we're talking about Barrett's, I actually think it's a really nice platform. I think it's a little bit easier to use and pick up those abnormalities in the mucosa than seeing a histologic pattern necessarily. And then I really think it's useful, again, for EMR. You can mark those areas, the borders of their irregularity. So if you're going to resect that area of Barrett's or that nodular Barrett's, you can resect that at that time. Again, you could target biopsies and maybe pick up more high-grade dysplasia than you would if you're just doing random biopsies of the whole area of Barrett's as well. The last modality I'm going to talk about is tissue cipher. So this is not an imaging modality. This is kind of trying to answer that question. Okay, we've got a patient with Barrett's, maybe even some dysplasia or metaplasia, and we want to know what is their risk of progression to esophageal cancer, because we know it's not there's a slow progression, and we know that not everyone progresses from Barrett's to esophageal cancer, and that risk seems to be different from patient to patient. And so tissue cipher, as the picture kind of shows, it's trying to be the crystal ball for us. It uses forceps biopsies specimens, so the specimens that you're obtaining anyway for the Seattle protocol, and you can send them out to this the lab, the tissue cipher lab, And it can predict the risk of Barrett's progression to either dysplasia or adenocarcinoma. It measures a combination of epithelial, immune cells, stromal processes in the biopsy to produce this risk class. And it gives you a high, medium, or low risk of progression. And so that may help you tailor your surveillance protocols to, okay, this patient may not need an endoscopy every year. Maybe they can go 3 years if they're on the very low risk group versus the high risk group. You may want to resect that area of high risk tissue. The sensitivity for this in the high risk group was pretty low, but the specificity was high. So they're, they have a little bit of work to do, I think, as far as like getting their risk algorithm to be as accurate as it can be. But these are some of the examples of the staining that they do. They do multiple staining. They use AI as well. It's not just, they put it through a whole AI and pathologist type of a screening protocol to come up with this risk. I think we all know that there is a challenge of determining who's going to progress. We need, as clinicians, I think we need better ways to not only identify Barrett's and catch more patients earlier on with Barrett's esophagus, but then once we do, I don't think our screening mechanisms are good enough. Screening every 3 years, we miss patients, or even if we're very diligent and we're doing the Seattle protocol, there's so many areas within that area. If we're just doing random biopsies, we're missing. So all these imaging modalities are there to help us find those high risk areas and be able to intervene earlier so that we don't have so many patients going on to esophageal cancer. I think in combination, if we can, I think the modalities that I've talked about, I think the send out lab is easy. That one is just, you're doing the Seattle protocol anyway. You can send this lab out to kind of get a risk score to understand who may be higher risk in your patients, and you may screen them more often or intervene in a more aggressive way. I think the other two modalities, the 9-point and Cellvizio, I think are really good for those high risk patients, like in the males in their 50s, that long chronic GERD that have long segment Barrett's, to really do a good screening. I don't think that's going to be part of every clinician's day-to-day protocol because of the time constraints. But I think for screening for high risk patients, those come in really handy. And I think those should be included in centers that are taking care of Barrett's patients, at least one of the two. That's all I had for you. That's what's on the horizon. I think it'll really help us as clinicians combat both Barrett's and the progression to esophageal cancer. Thank you.
Thank you so much, Dr. Houghton and Dr. Gata. That was wonderful. And we are on time, so we have about 20 minutes to go through some questions and discussions about aspects in using these techniques in clinical practice. I'll ask those questions first, which were posted on the Q&A section from Dr. Adam Chvisco. His question is to Dr. Gata. He says, what is the influence of PPIs on WATS 3D results? Should PPI be stopped before Seattle protocol or WATS?
That's a great question. So I was thinking about this. First of all, I thought I didn't know the answer, but then if you think about it, if you have a patient that comes in underdiagnosed or presenting for the first time with reflux disease, you get an endoscopy and the patient has severe erosive esophagitis, like grade C or D, Los Angeles grade. Typically what you would do is treat those patients because you can't biopsy them right now or biopsy them in an effective way to rule out Barrett's esophagitis. So you typically put those patients on 2 to 3 months of PPIs and bring them back So I would expect that a lot of patients who do get Seattle protocol or WATS biopsies are actually on chronic PPI therapy because these are symptomatic patients. So, I would also submit that I believe all of the studies and the effectiveness of both the protocol Seattle versus WATS are probably patients who have had chronic changes from being on PPIs chronically. I don't think it affects the efficacy or the yield in a negative way. I think that's just the disease set. Dr. Houghton, do you think any differently?
No, I agree with you. I think most patients that we're biopsying with Seattle and WATS are on chronic PPI therapy to treat their disease. So I think most of those patients, and it shouldn't affect it.
Yeah.
And if at all, it should help, as we often get this indeterminate for dysplasia patients who are basically untreated reflux injury, which kind of muddles the results. Therefore, I think I agree, as both the panelists said, continue them on PPIs or treat their reflux well before biopsying, just to get a clearer picture. Perfect. Next question from Anonymous for Dr. Houghton. Since Cytosponge is not commercially available in the United States, have we considered EsoGuard or EsoCheck, which is a silicone balloon that is commercially available in the United States and has more than 91% sensitivity and specificity?
Mm-hmm. It's probably bad of me to admit this, but I don't know of that modality. Prakash, do you, or Dr. Chandra, have you any experience with it?
Yeah, I'm sure I don't know as much as Dr. Chandra does, but I have seen, to me, EsoGuard appears to be, what's the protocol used for stool screening, like, the DNA, or you look at blood? I think it's a similar mechanism. It seems to make a lot of sense, especially if the cost is lower, there's no sort of procedure cost, and sensitivity is high. What do you think, Dr. Chandra?
So I have some experience, including trying to swallow one and did it successfully. So EsoCheck is the sample collection part of it, and EsoGuard is the patented technology to detect dysplasia or Barrett's metaplasia. To be frank, it was a challenge, and we were part of this lucid trial. And out of 8 people whom we needed for volunteering to be part of the site, only 3 of them could swallow it. So it has a thick catheter, and that kind of catheter gets stuck to your tongue. And to be frank, that was our experience. So the swallowing is the bigger challenge. Now, those people who are not aware of EsoCheck, it does have advantage of not scraping your throat because you basically put the catheter with the balloon into the stomach, inflate it, pull 5 centimeters, and deflate it. So kind of it's invert inside, so you don't scrape rest of the esophagus. So all the problems of Cytosponge, like getting gastric mucosa, still persist with EsoCheck, but does not scratch the throat. But the other thing I learned, that when you scratch your GE junction, you can still feel in the throat. So if somebody says dysphagia below the sternal notch means esophagus, that's not true. Anyway, EsoCheck has a good chance. Currently, it's available, and I think primary care doctor's office is the best place. We are planning to have it probably with our manometry lab, because those nurses have experience in making patients swallow the Bravo capsule or the manometry catheter. So that's administering it's a challenge, and you probably need a lab, and you don't get much out as a GI practitioner. So primary care doctor through the manometry lab is the way to go, I guess. Okay, our next question by Dr. Fanas. What happens if biopsies versus warts produce conflicting results?
Can I answer that? So I was thinking that, so the whole point of WATS is the yield is higher. So if for example, the same patient had Seattle protocol once and then WATS the second time, I would think with the yield of the WATS as being higher, you would obviously gravitate towards the abnormal results on the WATS. So So what I'm saying is the false negative rate is probably higher in the Seattle protocol. So if there is a disparity between the two biopsy techniques, I would obviously go with whichever one shows abnormality, even if it's Seattle protocol and the WATS was negative. So I would treat that as a, I'd be more concerned about the abnormal finding no matter what it was.
Yeah.
Right.
I agree.
Yeah.
I've had that situation. We usually would do the WATS and biopsy actually on the same patient. So we would do the WATS brush and then we would take some biopsies as well. And I found that if there was going to be even Barrett's found or any kind of dysplasia, it was more often seen on the WATS than it was on the forceps biopsy. Dr. Chandra,
that's consistent with our overall Barrett's management. You always make a decision based on the worst possible or worst histology detected. So if patient has high grade dysplasia once and the next time has low grade, you treat them like high grade. So that's consistent with the overall approach in Barrett's esophagus. I have a couple of more questions, and these questions are for both Dr. Gata and Dr. Houghton, about the WATS. In your clinical practice, who is the patient you're using? Are you using for surveilling a long segment Barrett's esophagus, or screening for people who have irregular Z-line, or looking for recurrence of metaplasia in a person who has Barrett's eradicated?
So the question is who is the target for WATS?
Yes.
Yeah. So first of all, since I do far less diagnosing of the disease, having a surgical specialty, this is a question that thankfully I don't have to answer often. But I would say that I think when you think about inter-observer variability, so I think the sort of irregular Z-line as a trigger to do more aggressive, treatment or workup, I don't think is very reliable. I think the long segment Barrett's obviously would be, the subset of patients as Caitlin had described, the sort of 50-year-old white male with long segment Barrett's, long-standing history of reflux, smoking, high risk factors, et cetera, would be the primary target. Now, I think we here in a society like this, if there are recommendations being made to Medicare, for example, as to who the screening should be done on first, as we have for colonoscopy screening, familial history, that would be that ideal subset of patient where you would have Medicare or a payer pay for screening. I don't know what you think, Dr. Chandra, but if you are 45, you're getting a screening colonoscopy, I don't believe the cost of an upper endoscopy at the same time is significantly higher as opposed to two separate visits. So, I think from in terms of a cost perspective for screening, I would select the subset of patients with a prior history, chronic history of reflux, all the risk factors, prior history of metaplasia, patients, for example, who've had prior anti-reflux disease and are still showing symptoms or evidence of esophagitis or metaplasia or Barrett's.
Agree. I also happen to believe that, or agree with the findings that we only detect 50% of esophageal cancer if we go by long-standing GERD and risk factors based strategy for screening for Barrett. So it's one way to go about it, but it's far from perfect.
Yeah, I think WATS, we do surveillance on some Barrett's patients, and I think I don't necessarily do it at the index procedure. If I'm doing, let's say I'm doing a workup for GERD for a hiatal hernia or something, and we're doing an endoscopy. If I see long segment Barrett's or if I see a significant tongue of mucosa, I think WATS is a good way to go. And then I think anyone that's being surveyed for Barrett's esophagus, I think WATS is a good adjunct because it gets the deeper tissue and it also gets a wider cell base. So the forceps biopsies, I feel like you can miss things and the WATS gives you a better just sampling more of the tissue. So I don't think it's good. I don't necessarily think for just an irregular Z-line necessarily though, because I think that you know, that may give you
Okay.
false negatives, I guess,
So I'll talk this.
or false positives. Sorry.
Agree. Yeah, that's what WATS groups would like us to use them for. But I agree, it's long segment Barrett's in whom you are trying to minimize the risk of progression to dysplasia or cancer is the right person. Another question regarding how to use WATS brush. If you can share a couple of tips on, do you use the brush to go back and forth? Do you use the whole scope to go back and forth? What would you take care about if patient has a hiatal hernia? Any bad incidents which we should watch out for?
I think Caitlin should answer that because having done zero.
Okay, yeah. So I think that WATS with a hiatal hernia, well, or even like a dilated esophagus is a little more difficult. Sometimes the angulation of the valve can just make it a little more difficult to get the cells that you want and get the scraping of the brush against the mucosa the way you want it. So there's so many variability in this. I tend to use the brush and go back and forth because I don't like my scope like going in and out of the mouth and scraping the whole length of the esophagus. So I tend to use the brush, but I know some of my partners like use the scope a little bit more. I like using the brush. I think you should be the one, the surgeon should be the one, or the endoscopist should be the one manipulating the brush instead of having your tech help you type of thing, because you can have a better eye. And I think we're a bit more careful. So those would be my tips. I think just watching the tip of it. I like using the brush because I think it's more controlled, and having whoever is doing the procedure actually control the WATS rather than having someone assist you with that.
Yep, that makes sense because the animation always looks easy, but when you do it, by the time you have finished your Seattle protocol, you already have everything bloody and visibility is not the best anymore, and being careful is helpful. Well, those were the questions I had. If you guys would like to share any more insight about Cellvizio, can we mark the site from Cellvizio? Is there a marker like you have in
that I'm not too clear about that. I haven't used it much, so I don't know if you can mark the site. I know that is the feature of the 9-point, which is nice.
Yeah.
So I don't think there's from what I understand, I don't think there is like a within the probe itself something that will mark it for you like the 9-point.
I had a quick question for both of you, which was that which of the newer technology is actually paid for? Are there billing codes? Are there writers to a standard endoscopy that how does that happen? Does that happen?
Chandra, do you know?
Yeah. So WATS 3D brush. So they bill the patient separately. So it's not you don't bill the patient, or your facility does not bill the patient. It's the third-party billing, and it's a little bit. They keep it a little bit vague, and that their goal is to get paid as much as possible, and then ask the patient to pay, and then let it go.
So covered by insurance. Is it something that insurance covers?
Insurance do cover. Insurance do cover. None of my patients got angry with me when I did WATS brush. so far so good. But if they do, the company does bill separately. So the billing is done through the company, not by your facility.
It's interesting because I would hope that if it's a billing issue where patients can be told, if you want this newer technology, you have to pay more out of pocket, and patients may opt out of the newer technology such as WATS, and hopefully that's not happening is essentially the reason I was asking.
Yeah, so how I've been going about it is that I would inform the patient that this is what we are doing, and you will be getting 2 different bills, one bill from our facility and then another bill for the WATS 3D brush, and inform them why choosing WATS versus just what we were doing before.
Yeah. Dr. Chandra, I know in a busy practice, we endoscopists or anyone doing endoscopy, there's a lot of pressure to get a lot of people through and kind of keep it keep it moving. And some of these newer modalities, like the imaging modalities, like cell visio and 9-point, they take time. You have to slow down. You have to take your time. They are a little more intensive. How do you see that playing out in a busy endoscopist practice? And do you think it's feasible to ask people to do it?
Well, that goes back to your point about these things should be taken care by centers of excellence. And in those places, I think we do have less move the patient issue. On the other hand, if all the GI societies, at least they agree that we should be spending about 1 minute per centimeter of Barrett's esophagus, examining it, commenting on the mucosal pattern, the vascular pattern, use of NPI, or just high definition. So it is, Barrett's surveillance is time consuming by all means, including the biopsies, and it's a messy business. So it should be done by people who are ready to take time and to the best patient needs.
Mm-hmm. I think the proceduralist, the GI proceduralists who are doing EMR, I think those things are helpful to help gauge. I don't know what you're doing now. Are you using mostly endoscopy? I mean, ultrasound to help gauge those margins, or is it just visual?
We have been going by EMR being the best staging tool for Barrett's dysplasia. So we go by imaging anything abnormal, be proactive in doing the EMR. We so far don't see a role for EUS, at least amongst the gastroenterologists, is that if you find we say it should be done by a person who feel comfortable doing EMR, because if you don't do EMR, you'll make a case to not needing an EMR. So it should be done by a person who is liberal in doing EMR. Any abnormal area should be EMR'd, and that's the best staging. EUS in the mucosal level has not been that helpful so far.
Yeah. So are you using one of these modalities to help you gauge the margins then, or are you, it's basically visual?
Just based on high definition, maybe some NBI.
Mm-hmm.
Okay. Well, that brings us to 5 p.m. And thank you so much, you guys, for doing this.
Thanks, Dr. Chandra.
Yeah.
Good to see you, Caitlin.
Yeah, good to see you.
Thank you,
Thank you for the
Thank you, Dr.
opportunity to
Malcolm.
speak.
Thank you. Bye-bye.
Ready.
Thanks,
Bye.
everybody.